Chapter 24, Musculoskeletal System. These are the Chapter 24 objectives. Describe the structure and function of the musculoskeletal system. Discuss osteoporosis and ways to reduce one's risks and promote joint health. Discuss an accurate history of the musculoskeletal system. Be informed about the physical assessment of inspection, palpation, and range of motion for the system. Differentiate between normal and abnormal findings. Describe the expected aging changes of the bones, skeletal muscles, and joints. And describe findings that might be noticed with the older adult. And the tests for the musculoskeletal system, including those for carpal tunnel syndrome and the knees. So when we start talking about the review of systems, we need to understand structure and function. So I would encourage you to review some of the structure and function maybe that you learned in anatomy and physiology and pathophysiology. We need to know not only what the names of these parts of the anatomy are, but also what is their purpose, what is their function. So here is a skeleton that has all these critical bones. Many of them we are going to use for landmarks in our assessment procedures throughout the semester. So review this information so things will make sense to you, where things are located, what they are doing, and what their purpose is. Also, skeletal muscles. We talk about smooth skeletal muscle, cardiac muscle, what's voluntary and involuntary muscles in the body. A lot of these things you will want to review for yourself as we talk about this. You need to understand what the movements are. They have what the different names mean: abduction, adduction, circumduction, inversion, eversion, extension, flexion, pronation, supination, protraction and retraction, and rotation. So these movements help establish mobility of specific joints and are part of different assessment procedures. To get full range of motion, some of these joints will do these things and some of them will not. So you need to be aware of which joints can move in these specific ways. So here's a picture of your skeletal muscles. A lot of these muscles we will talk about throughout as we are providing assessments. Many of you know the most common ones, your tendons, ligaments. You hear about these with sports, celebrities, etc., that have injuries to these things. But we also use some of these for landmarks, such as the trapezius, the sternocleidomastoid, deltoids. We do intramuscular injections into deltoids, as you well know. Also, your quadriceps and hamstrings, very commonly, and gastrocnemius, all those things. So be comfortable in knowing where some of these major muscle groups are that we use to identify locations. When we talk about joints, you need to know what are the different type of joints and why. Why are some joints immovable, and some of them that are between the vertebrae, your disc, things like that. Why are they like that? A lot of it is related to mobility, of course, how things need to move to help the body be functional. What are ligaments? What are tendons? What is their purpose? So here is a picture of some of the actions that we talked about. So when you're thinking, for example, as the neck, does your neck pronate and supinate? No, of course not. Your neck has this mobility. Flexion, extension, hyperextension. They also have lateral rotation. So be thinking about that when you're talking about assessment procedures. What makes sense? How do these joints move to establish a full range of motion? We're going to talk about your temporomandibular joint. And this is the joint that opens and closes your mouth. You can feel that joint right in front of your ears. as your mouth opens and closes there. Also the other range of motion, the elbows, the shoulders. Be sure that you know what are the motions that these joints can do, because not every joint can do the same thing. Think about your vertebrae, your flexion, hyperextension, lateral bending, and rotation. This may be compromised if patients, for example, have scoliosis or kyphosis. This may be a concern there. Your hip flexion, knee flexion. We perform a lot of those things when we're getting up and walking. So patients who have hip surgery, knee surgery, this is a real challenge for them. Plantar flexion and dorsiflexion, we do that in the hospital setting to establish range of motion of the ankles, and you'll see that very frequently. So a big problem in the hospital setting is osteoporosis. This is the thinning of the bones. This puts your patient at risk for fragility fractures, and quite often this can be uh, a a diagnosis that causes your patients decreases their mortality significantly if they have falls. So we want to identify for this patient what might put them at risk for osteoporosis. So gender, age, body size, history of osteoporosis definitely is connected. Long-term glucose steroids, rheumatoid arthritis. Some modifiable factors that we have found is alcohol use and smoking can precipitate somebody towards osteoporosis, that thinning of the bone. Insufficient exercise or weight-bearing exercise can also decrease the building of bone. Here's a picture of that osteoporosis, and you can see for the healthy bone, if somebody fell, there would be enough structure within the bone maybe to help support the patient and prevent a fracture. But when that osteoporosis bone, it looks almost like Swiss cheese. If there is a ground level fall, there might be a fracture right at the neck of that femur. So we encourage our patients, we monitor their calcium and vitamin D, encourage that intake and adequate nutrition. Also weight-bearing exercise, which builds bone structure. Reducing smoking or quitting smoking altogether, reducing alcohol consumption. These are very important. We want to decrease the risk of fractures for any patients, decrease the risk of falls, because this decreases their mortality. So we take this very seriously and try to identify these things for our patients. So when we collect subjective data about musculoskeletal health, we ask, is there any history of recent weight gain, any difficulty chewing, pain, joint, muscle, or bone pain, such as osteoarthritis? Maybe stiffness or swelling, limitation of movement. Sometimes those limitations of movement can identify maybe some stress fractures or even some rheumatoid arthritis. In the past health history, have you had any injuries, broken bones, history of diabetes, sickle cell, lupus? A lot of these things will impact your bone health. Rheumatoid arthritis, gout, and osteoporosis can have genetic components, so we want to identify that for our patients as well. And again, we ask about their activities. Are you exercising? What type of medications do you take? Definitely steroids, things like that will impact your patient's bone health. So when we collect objective data, we're going to observe their gait. Do they have a rhythmic coordinated gait? Are they limping, shuffling, uneven weight bearing? A lot of times patients are uneven weight bearing because one leg hurts, and so they limp on that leg and don't want to bear weight completely. When we assess for fall risk, we might do some other tests like the Romberg. If the patient is doing that, we'll talk more about that as we go into the neurologic. But we want to assess for fall risk. Has your patient fallen before? Do they have a history of back or neck pain? And Parkinson's reduces stability for your patient. When we assess the joints and muscles in your tables 24-1, our assessment procedure includes your inspection and palpation. So we inspect for shape, color, symmetry, noting any deformities unilaterally or bilaterally. We palpate for heat, edema, tenderness, and pain. Those things might be related to inflammation or infection. Crepitus may be related to air that is contained underneath that tissue. So when we check for range of motion, we do passive range of motion and then active. If your patient very obviously can do active range of motion, then we would establish that they would be able to tolerate passive range of motion. But if the patient cannot do active range of motion, which means they move that joint on their own, then we would take the joint through the range of motion passively, which means that the nurse would do that. So when we test muscle strength, a lot of times we will provide resistance, which means we put our hands on the legs or the arms, and we have the patient push against us. If they have full strength, you can feel the strength in that. But we're going to do those at the same time, so you can assess whether there is weakness or unilateral weakness. That is very important. If the client cannot move the part against resistance, then we would ask them just to move it actively. So looking at these pictures, you can kind of see these guys are not having a good day. A lot of times our professional athletes may have stress fractures, but then they have one good break and it breaks all the way through. As you can see, this one patient's shoes are facing completely the different direction. That is not a good deal. He dislocated his right ankle and broke his right leg. So obviously that will have to be repaired. That is not going to be something you're going to be able to walk off the field with. This other basketball player, he broke his leg all the way through, and you can kind of tell if his shin guard wasn't on there, you would see that bone protruding through the skin. So these fractures are significant and must be repaired. The alignment must be retained in order to have function of those bones. So again, active range of motion, passive range of motion. This is how you do those procedures. But limited range of motion is the most sensitive sign of joint disease, whether it be limited because of pain or because of swelling, something like that. But it is the most sensitive sign of joint disease. So here's another picture of these skeletal movements and how to test your strength. Now the range for strength should be from 0 to 5. 5 is the best. So we would always need to have that scale. So here is a table of this muscle strength for you. And we also chart this on each patient, and we'll do it with each extremity. So we want to compare and do each extremity, upper and lower extremities at the same time. So when you feel that crepitus, like we talked about earlier, that's that crunching sensation with the joint movement. Sometimes that can be happened with or without pain. Well, here's a picture of that temporal mandibular joint there. So when we're talking about that temporal mandibular joint. We talked earlier about how you assess that with the index and middle fingers there. So know that the full range of motion is that the mouth opens 1 to 2 inches. Snapping and clicking may be heard, but the abnormal finding is that there's pain and decreased range of motion. So that would be something that you would identify as an abnormal finding. Now, when we talk about the spine, thinking about the cervical, thoracic, and lumbar spine, just like we assessed in the pictures, what are some of the symmetry findings? You would expect these shoulders to be even height, and identifying any abnormal curvature of the spine would be important to document. So here's a picture of that spine, the lordosis of the spine, the kyphosis of the spine. We also have scoliosis, which is a lateral curvature. So identify how you would do assessment procedure to see those things. We're also looking limited range of motion and decreased range of motion to resistance. So lateral bending, rotation, flexion, extension, and hyperextension would be the range of motion there. So here's a picture of the scoliosis, that lateral curvature. Most of you in elementary school, they would have you bend over and identify, because when you're bending over, you can see the asymmetry of the height of the hips and asymmetry of the shoulders. So in the shoulders and arms, they should be symmetric without any redness, heat, or swelling, any tenderness, full range of motion, and equal strength. And for the arms and elbows, symmetric without deformities, redness, tenderness, any tenderness to joints, etc., or limited range of motion might indicate diagnosis or disease. So some other abnormal findings may be dislocation, nerve or muscle damage, muscle atrophy, any shoulder strain, rotator cuff tears, tendonitis, any nerve damage, like in cranial nerve 11, their inability to shrug shoulders to resistance. So we're always looking for arthritis. Again, it's that inflammation, redness, heat, and swelling. With rheumatoid arthritis, you might see deformity, nodules, things like that to the hands and elbows as well. Tenderness or pain into the elbows. Sometimes with athletes, this may be related to repetitive motions or movements. Some patients who have done sports in the past might have had that experience where they have some injuries there that they contend with. But decreased range of motion or decreased strength might be related to disease or injury, so we will always further focus our assessments if somebody has an abnormal finding. So here's range of motion for the shoulders, and you'll see there is multiple different things that your shoulders are able to do to identify a full range of motion there. So your wrist, we look at wrists a lot, especially in this age of technology where patients and employees are on computers all the time charting. We assess for carpal tunnel. We use the Phalen's and Tennell's test, and we will show you a picture of how that we do that. But we're looking for tingling, numbness, pain, things like that. Where that nerve is being impacted into the wrist just from positioning, etc. We're also looking for weakness, and this may be in one side versus the other, if somebody has an injury on one side versus the other. So we will provide those assessments. So here's a picture of the Phalen's and Tennell's. If the patient is positive for carpal tunnel, this Phalen's test, they may have some numbness with this positioning there. So swelling and tenderness, nodules, like I said earlier, may be related to some rheumatoid arthritis. If patients have fractures, they may have pain or tenderness and possibly decreased range of motion to extremities. A lot of times, if patients have history of fractures to fingers, etc., they may have limited range of motion for a very long time. The carpal tunnel syndrome, again, like we talked about, numbness, tingling, pain, or shocking sensation or weakness to the thumbs might be findings that people would see. So hands and fingers are normally symmetric, non-tender without nodules. You'll see as we look forward to osteoarthritis, you might have Herbert's or Bouchard nodules for patients with that osteoarthritis as swelling and discomfort later on. When you look at the hips, we again are assessing for symmetry. We want the hips to be stable. We want them to be symmetric in height and have full range of motion. So here's a picture of Herbert's nodes and Bouchard's nodes related to osteoarthritis. Some abnormals from the hands and fingers again, pain and tenderness, swelling, rheumatoid arthritis. You may identify more as a swan neck deformity where there's more nodules on the knuckles of the patient and the fingers are deformed into that swan neck. As with either of these joints, if there's limited range of motion or strength, we might identify that with some arthritis. So with your knees, they should again be symmetric. They should be non-tender and cool. Full range of motion, equal strength. Should be no pain or clicking or crepitus. Those are all abnormal findings. So we see patients with genu valgum or genu varum, knock knees or bow legs. These are abnormal findings there. Any swelling or fluid around the patella would be an abnormal finding. Osteoarthritis and osteoporosis obviously those are abnormal findings. So here's a picture of your knees and how the cartilage is affected. And your ankles and feet, you should be able to plantar flex and dorsal flex with the full range of motion. They should be in alignment with that lower leg. The skin should be free of corns and calluses. And most weight bearing is on the midline foot, but you might see with somebody's gait that they may have, weight bear on their toes or weight bear on their heels. That can be different for different patients. But there should not be any pain, heat, or swelling in either way. Full range of motion and equal strength to dorsiflexion and plantar flexion should be present. So again, abnormal findings might be a laterally deviated great toe with hallux valgus, flat feet, corns, calluses, gouty arthritis. A lot of times that's in that big great toe. Rheumatoid arthritis affects the feet and decreased range of motion, decreased muscle strength. We would assess for those things as well. So here's a picture of gout, that excess uric acid that's found in the great toe that causes pain and redness and swelling. So rheumatoid arthritis, just so you're able to differentiate rheumatoid versus osteoarthritis, we relate rheumatoid to a chronic systemic inflammatory disease of the joints. There is a symmetry of this inflammation in the joints, and the pain and stiffness typically is worse in the morning. And then movement decreases pain sometimes. The deformities a lot of times are related when um, there is decreased movement and patients are joints are contracted in a way. So there are some braces and things like that that patients with rheumatoid arthritis use to help prevent deformities. So here are all the joints. I mean, this is essentially all, and it can affect their hips as well, but it typically affects these most peripheral joints first. And it affects them on both sides equally. It's systemic, so that makes sense that it would be all over, right? Osteoarthritis is a non-inflammatory, localized disorder. Sometimes it can affect one side versus the other. It can be at specific joints, maybe specific knees, etc. Is very commonly hands, knees, and hips. Assessing the neurovascular system includes providing assessment for circulation, motor, and sensation. So this is critical if there is an injury or fracture, or if there's any casting or restrictive type bandages. Because in patients that have injuries, there may be swelling in those areas. And recognizing that compartment syndrome can help preserve the blood flow and the nerves to that extremity. So the different neurovascular pieces that we look at are pain, any decreased movement or sensation, any changes in pulses or capillary refill, the temperature and the skin tone of the extremity, and if there is any pressure that might be noticed. If there are changes in this neurovascular assessment, this could be a medical or surgical emergency. So here's a picture of this swelling to this left calf here after an injury. And the pain is increased, there was swelling there. And so what had to happen is we opened this leg up with a fasciotomy. And you can see how swollen that gastrocnemius muscle is. And so if the swelling is so much and there's nowhere for this swelling to go, it puts pressure on the vessels and the nerves and the tissue. So we would open this up in a fasciotomy, and then we would allow the muscles and the tissue to reduce swelling over time, and we would provide incisional care for this patient's wound to heal as the swelling is going down. But without this being this assistance, the patient could lose their leg. So some of the nursing diagnoses for musculoskeletal health are the impaired physical mobility, acute pain, and chronic pain. In summary, you will need to know what are some of the main skeletal muscle movements and which joints perform these. We also look at some of the older adult considerations for this chapter. For example, there may be some impaired positioning, maybe some stiffness, limited range of motion can be related to osteoarthritis, but we want to be very careful with these older adults when we're doing range of motion because they're at risk for falling. Um, so the other things that older adults may see is that thoracic curve called kyphosis, and also that we don't do excess resistance when we're doing range of motion because we know sometimes the strength in some of these joints are impacted. So being careful in those ways. Also, we are looking at just their overall discomfort and the baseline of the older adult is their strength may be weaker than you might expect for a younger adult. Now, we also are looking at what are some of the risk factors for osteoporosis, what the nurse is assessing through TMJ, the cervical, thoracic, and lumbar spine, the upper and lower extremities, and any spinal curvatures. We are looking for abnormalities affecting the wrist, hands, and fingers, and also the difference between rheumatoid arthritis and osteoarthritis.